I'll be discussing about post-vaccination myocarditis. Now, this is not specific to post-COVID vaccine myocarditis. It is just a post-vaccination myocarditis, but then we can also gain some insight about what could be happening behind this. Post-vaccination myocarditis it's a rare entity, and we'll just be reviewing the literature about what we have so far. Okay. So this is a case study. This is a 27-year-old male who had a strong family history of atherosclerosis. He had undergone a splenectomy for a trauma, and he was taking periodic vaccination. So he had actually, when he had come, he had received this Pulmovac vaccine about 4 days ago, and he had presented with fever and some induration at the injection site. And he had severe myalgia, but he had no chest pain. So ECG was just done as a part of a routine screening in the casualty, which showed some ST elevation. I'll just show you the ECG in 2 minutes. The tropi was positive. Now this is not an HS tropi, this is a normal tropi. So normal tropi, our cutoff was 0.04, 1.4 was significantly positive. So essentially we are a 27-year-old male with a strong family history of atherosclerosis, with fever, with ST elevation, and with a positive troponin. So this is the ECG. So as you can see, there is some ST elevation in the anterolateral leads, mainly in one AVL, V4, V5, and V6. It's concave upwards. So this is another ECG subsequently. So one AVL, V4, V5, and V6. So this was his 2D echo. So in the echo, there was no clear regional wall motion abnormality. So these are the short axis views, short axis cuts at mitral valve, papillary muscle, and apical levels. These are the long axis cuts. So apical 4-chamber view, a 2-chamber view, and a 3-chamber view. And there's also a short axis view. Essentially to show that there was no regional wall motion abnormality to suggest that there could be an acute coronary event, but still, because of the strong family history, we went ahead with a coronary angiogram, and this is what it showed. So this is a coronary angiogram done through the radial route, which shows that both the LCX and LAD are normal. This is another view showing the same thing. There is no plaque. This is the right-sided artery. This is the RCA, which also shows that the right vessel is normal. So just to summarize, we have a young male who presented with chest pain later on. Initially did not have chest pain, with a high troponin value, no abnormal echo findings, and no abnormality on the angiogram. So we have these as the differential diagnosis. One could be that he had an MI and the vessel got recanalized, but it doesn't show that way clinically also, and as well as on the echo or on the ECG, because usually we would have something on the echo. ECG will later show a T-wave inversion, a progression of an MI. That is not there. There could have been a flush occlusion of a branch, which was not clearly visible, but the angiogram was studied very well. Third was that if you had a high intensity prolonged exercise, that can explain the elevated troponin in the presence of a normal angiogram. If he had a tachycardia outside, which reverted, and hence there is a positive troponin, then myocarditis and Takotsubo's cardiomyopathy. So Takotsubo's cardiomyopathy is also called as stress cardiomyopathy. So usually it is present in elderly females whenever there is a sudden surge of emotion or stress, and then you have a typical apical ballooning syndrome that is seen on the echo, with or without ST elevations on the ECG and an elevated troponin. So these were his differential diagnosis. So essentially we were able to rule out the other things, and I'll tell you what happened then. We got his cardiac MRI done. So in the MRI, we don't see again any regional wall motion abnormalities in the long axis as well as in the short axis. And so these are the LG images. So the LG images show a mid-myocardial enhancement in the lateral area. So, and it is a very focal area. It's only in this area where there is a mid-myocardial enhancement. So same thing again in the anterolateral wall, there is a mid-myocardial LG. This is our longitudinal strain layer-wise analysis. So in summary, he had a myocarditis. So why did he have myocarditis? Possibly, so this entity has been defined as an autoimmune or an inflammatory syndrome that is induced by adjuvants. So our patient had musculoskeletal symptoms. There was an external stimulus. Obviously, there was nothing to withdraw because it was just a single vaccine. Antibodies we did not see, but this was the overall definition of post-vaccination myocarditis. So we'll just have a quick background of what it is. So these reactions have been described after papilloma virus and hepatitis B vaccine immunization. One case which has been reported is in the influenza vaccine. Earlier it was called as Schoenfeld syndrome, where post-vaccination patient had a lot of myalgia and or myocarditis. So in this patient, which was reported otherwise, this patient had rhabdomyolysis. Our patient did not have rhabdomyolysis. So what are adjuvants? So essentially, when vaccines first came into being, they used to take the pathogen, try to make it attenuated, and then give it to the recipient to develop immunity. But essentially, as they started making it purer to have lesser adverse reactions, the immunogenicity of the vaccine also became weaker. So to increase the immunogenicity of the vaccine, but not to give the entire virus, they started adding these adjuvants. So adjuvants increase the immunogenicity of the vaccine, but they are not the true pathogens itself. So in the newer age vaccines, you have antigens. You don't have the whole virus, you have antigens, and plus you have the adjuvant. So these reactions are initially, and these are mostly to the adjuvants and not to the vaccine antigen itself. So this is a very busy slide, but these are the adjuvants that are commonly used. Aluminum is used. Then this is squalene, this is used in influenza vaccines, and multiple other adjuvants are used. So what is the pathophysiology and how does this vaccine lead to myocarditis like in our case? So initially, when the vaccine is given, at the local site, there is a local reaction, and followed by which the antigen or the adjuvant is taken here, presented by the antigen presenting cells to the local lymph nodes. And from there are either two reactions. One is an acute phase reaction. The second is an autoimmune reaction. So you can have any one of these. You can have an autoimmune thyroiditis, a hemolytic anemia, a vasculitis, a GBS, an autoimmune myocarditis, which our patient had, a scleroderma, and an autoimmune arthritis. So it's basically essentially like a molecular mimicry. What are the diagnostic criteria for this? Is called as ASIA. So what are diagnostic criteria for this? One is myalgia, myositis, which our patient had. In addition to these things, neurological manifestations, cognitive impairment, removal induces improvement. So our patient got better after 4 days. So any two major criteria would be diagnostic for this. Minor criteria are appearance of antibodies directed at the suspected adjuvant agent or specific vulnerable HLA phenotypes. So the take-home message from this is that this ASIA syndrome or autoimmune inflammatory syndrome is induced by the adjuvants and not by the virus antigen itself. Significant complications are rare. So these are mostly limited to case reports only. They are not a very frequent finding. So vaccination remains an effective tool. So if you see the risk-benefit ratio, the benefit is that you can protect all individuals of all ages. This for flu especially. It reduces emergency room visits, hospitalization and death. And finally, that we should keep this in mind as an emerging clinical entity, because post-COVID vaccine, there are a lot of isolated reports which are coming out of there being clots or there being autoimmune reactions. So this is one of the possible pathophysiology that can be there behind this clot formation. And finally, should not discourage people from taking the vaccine. So that's all. Thank you.